Thanks very much, Barry. Pleasure to be here, and I've really enjoyed those presentations. When Barry contacted me and asked me to talk about this, I asked him what he wanted me to talk about, and I think he wanted me to teach you all how to be rural surgeons, and I'm not going to try and do that, but I am going to focus perhaps on the interaction between rural health services, rural surgeons, and our metropolitan-based colleagues. So you all know where Bendigo is, in the epicentre of Victoria there, and also look at the way even a small state like Victoria has pretty big rural health regions and not necessarily aligned for best impact as far as health services go. And I was reflecting, thinking about this before we started, what makes safe surgical practice is what we were talking about, and we've heard quite a bit about this from the other speakers already, but clearly case selection is extremely important, and I would argue all these things are more important in a rural area because we are not centres of resources, we're still centres of excellence, but we're not centres of concentrated resources. We clearly need to do surgery well, and we need to have good aftercare, and we've heard about early recognition of problems and then rescuing patients when they get into difficulties. I'm going to just use a couple of cases. They're real cases, and this one's even from this year, to just illustrate perhaps some of the issues and some of where we need to go. So look, here's a 68-year-old female. 2 days after a low fall, fell 2 steps off a kitchen step, was actually seen and assessed and sent home, and been found by her daughter 2 days later, deeply unconscious, very low GCS, fixed dilated pupil, and a really thumping big subdural. And rapid assessment in our ED, rapid phone call to consultant surgeon, and a clear indication to take this patient to the operating theatre, because guidelines would suggest if we can't get this patient in an operating theatre in less than 2 hours, and believe me, strangely enough, I can drive from Bendigo to here without breaking the speed limit in 2 hours, but there's no way I can get a patient into a metropolitan operating theatre in less than 2 hours. So the advice would be to contact a consultant neurosurgeon to discuss the case, and indeed, we took our emergency department physician came with me to the theatre, not because I wanted assistance with the operation, but I wanted assistance with the communication. And the first successful contact with the consultant neurosurgeon was after I'd started operating. And in fact, he was very, very helpful and gave some really useful advice. And then during that case, I rang him back because I wanted some advice about how to stop this horrifying bleeding that I seem to have caused. And that was also very helpful. There was a discussion with ARV about the best method of transfer for this patient, and they made the decision that it would be a paramedic helicopter transfer. We've got a service based in Bendigo, but it's based at the airport, and to get there you've got to drive in a road ambulance. This is a slow and tedious process. It took the paramedics nearly an hour to get the patient ready just to move out of our operating theatre, let alone to get to the airport. And the flying time by helicopter is about 35 minutes, I think, from Bendigo. That case, on arrival at the Alfred, had a satisfactory appearance, surprisingly enough, on the side that I'd operated on, and there was a small collection on the other side, I would say, drained, and perhaps not surprisingly, that injury didn't do very well. In fact, the patient did not recover. But I still think the right decisions had been made, and that the patient had been given a chance for survival, and probably her only chance for survival. This is pretty apt in view of Wendy's previous talk, and this is a patient who's 52. He's had quite a bit of contact with bariatric surgeons, so we didn't know all these details at the time, but he'd in fact had a laparoscopically adjusted band, then a sleeve gastrectomy, then some surgery for a leaking sleeve gastrectomy, followed by a duodenal switch operation, whatever that is, left with a large incisional hernia. And the operation's been relatively successful. He's down to 140 kilograms. He's in hospital because he's got a proven pulmonary embolus, and he's on a pretty large dose of enoxaparin. And it's about 4 o'clock in the morning on a Sunday morning, and he has a large haematemesis. We take him to an operating theatre, we do a gastroscopy, and we can see a lot of blood and not a lot else. Patient's blood pressure is 60, his pulse rate's 130, and seems like an ideal case for interventional angiography, except it's 4 o'clock on Sunday morning and you're in Bendigo, and not possible. not safe to transfer, so a laparotomy. And indeed, after 5 hours of operating with 2 consultant surgeons and what seemed to be some horrible false aneurysm or something connecting vaguely with the GI tract, we were left with a patient who had no arterial bleeding but ongoing venous ooze and showing all the signs for abbreviating the laparotomy, if that would be a fair description after 5 hours. And exhausted surgical team, but also an exhausted blood team in our own hospital, 25 units of blood given so far, and not much left and not many factors left. Again, discussion was pretty helpful. So, and we did have some phone discussion with a surgeon at one of the major metropolitan hospitals who said, oh, is that Joe Bloggs? And he was able to give us details of the previous surgery because he knew all about it, which was more than we did. We took the patient to packed and took into our intensive care, and then we had, I think, quite a useful discussion between a metropolitan surgeon, a rural surgeon, a metropolitan and rural intensivists, and of course each with the desire to get this patient either out of their hospital or not receive their patient into their hospital. And in fact the ARV retrieval doctor was actually very helpful in negotiating the best outcome, and we decided to wait because we didn't think transferring this patient instantly was going to make any difference. But with some more resuscitation and some factor 7 and a whole lot of other things, we got the patient to a stage where we could be retrieved about 6 hours later. And indeed, pleasingly, by the time he got to the tertiary centre, he didn't need to rush off to the operating theatre. In fact, they were able to do things the next day. Unfortunately enough, one thing led to another with that patient, and he actually died 6 or 7 weeks down the track. So, what do we think about this? We've heard about emergency surgical services, and when I was president of General Surgeons Australia, we developed this course. General Surgeons Australia developed this course, the Moses course, and it's designed to teach, in this case, general surgeons, but it's widely applicable for surgeons, how to make good decisions in emergencies. And this algorithm, which we've published, so I'm allowed to present it to you, talks about assessing the patient on the left-hand side. And whenever you're in a rural area, you've got to think hard about your personnel. Who's there? Are they available? What's their experience? How fatigued are they? And you are pretty fatigued after 5 hours of operating on a patient like I just described. You've also got to look at your environment. So what are the facilities? What equipment do you have? So I just thought we might talk about what rural hospitals may or may not have. Sorry, I've gone too far. So look, larger regional hospitals like mine, we've got really good anaesthetists. We've got a really nice intensive care unit. We've got some nice modern CAT scanners and MRI machines. We've got trainees in most disciplines. We've got a range of surgical specialties. We do have good comprehensive cancer care for many cancers. We've got on-site cardiologists that can do useful things now. So that's good. But even the largest regional hospitals probably or may not have interventional radiology. If they do, we've got it on Wednesday afternoons, but we're not much used the rest of the week. We don't have specialist vascular surgeons, or we may not have. We certainly don't have neurosurgeons. And for some of the smaller specialties, they don't have trainees. So you need to have a bit of sympathy for your ENT surgeon ringing up, because he's probably doing that, or she, all on her own. And then we go to smaller hospitals around, and the smaller hospitals may well be dependent upon general practitioners for anaesthetic services, for obstetric services, and in their emergency departments. The surgical service might be visiting. Junior staff probably limited both in number and experience, and radiology will definitely be teleradiology. And transport, well, patients come a long way to see us quite often, and inter-hospital, I can't stress upon you enough how slow inter-hospital transfers can be. There's literature to suggest that road is quicker than air, but the current trend is to do more air transfers. It's probably safer for the paramedics involved, and basically we've got the equipment, the helicopters and planes, they're going to fly. One of the things that we've strongly pushed, and it's synergistic with what Anne-Marie was saying earlier on, is about acute general surgical units or acute surgical units. There's a lot of literature around. Australia almost leads internationally in this field, and we established an acute general surgical unit about 5 years ago. We average somewhere between 7 and 10 admissions a day, which makes us a sort of a medium-sized unit, and about half of them need an operation. So it just interested me as I was thinking about this talk. I looked at, thinking it was all about VASM, so I looked at just 5 years of my own experience, so I still do on call, and 5 years, 780 procedures, which seems quite a lot when you think about it, and 1 in 5 of them died, 1 in 50, sorry, 1 in 50 of them died. And on the left are some of the reasons that people died that I thought I had no great control over. But then I looked at the ones that I put on the right-hand side of the slide, and it may be my fault, or it might be a system fault, or it might be someone else's fault, but there was certainly the opportunity for preventing some of those deaths, in my opinion. And if you want to interact with VASM a lot, just come and do some on-call at a regional hospital. You'll be interacting with VASM. Bit of a comment about operation and transfer. So this is a common situation where someone has a surgical problem, and I showed you 2 of them, who actually need an operation, but they also need transfer for a variety of reasons. What do you do first? Well, I find usually anaesthetists and often intensivists, anaesthetists will demand an ICU, which may or may not be full. And if your ICU is full and you put a post-operative ventilated patient, this can paralyse a hospital the size of mine. It can be devastating for hospitals even smaller, how to manage this situation. But so it's much easier to say defer the surgery and transfer. That's administratively easy, but it's not going to be the best thing for the patient if they're bleeding, if they've got severe sepsis, or if they've got something going on in their head. And I think many of you will have seen this clinical communique from the Victorian Institute of Forensic Medicine quite recently, pointing out 2 deaths in Victoria, one of which both were regarded as highly preventable, one of which was an unfortunate woman who had an ectopic pregnancy in a small hospital, marked delayed a transfer to definitive care for what should have been a pretty simple surgical procedure, and the other patient who had delay in recognition of sepsis. And what were the conclusions from the reviewers who talked about that? They talked about the lack of local knowledge, because we've centralised our ambulance retrieval services, and indeed it's my opinion, many people have no concept of the resources or lack thereof in various hospitals. It also stressed the point about communication, and stressed that this ought to be at a senior level, and also talked about rapid transfer rather than waiting for retrieval teams for some of the things we're talking about, bleeding or severe sepsis. So there I am, I'm on the phone, and amazingly enough, there'll be something next to the phone, but I think this communication is often done extremely poorly. I'm continually disappointed in the communication between surgical doctors, from A&E departments to surgeons, and clearly there is a recommended method to do it. Virtually every hospital, next to every phone in every hospital in Victoria is this little acronym which no one uses. And I really want to stress it. This was designed by the US Navy. It was designed for communication with their nuclear submarine drivers, because these guys can obliterate the world if the communication's poor. So get the communication right, and you know the backgrounds. And clearly the key here is the assessment should be accurate, and the request has to be clear. I found myself in the coroner's court a decade ago because I'd been communicating with one of my colleagues, and looking back on it, my assessment was accurate, but my communication was not clear, and it landed me in the coroner's court, and that's not a comfortable place to be. So you need to know what you want. Do you just want reassurance? Do you want advice? Do you actually want transfer? I don't think you're going to get too many people come and drive up and give us help. We don't generally think that's going to happen. And if you just want advice or reassurance, there's some more terrible heads we occasionally see, and we can now transmit these images quickly, which is good. But if it's transfer, what do you want? You want a single contact person, and yet we often say, I'll ring you back, I'm not sure. You don't want that. Yes, we'll do it. And as in the cases that I outlined, particularly the first one, we mobilised the transfer even as the operation was just starting, because we knew we were going to need it, and we didn't even at that stage know the ultimate destination of the patient. So things may need to move quickly. Consultant to consultant communication, really important, but how often does it happen? And in the 2 cases at the Forensic Medicine Institute was highlighting, communication was delegated to junior doctors, junior doctor to junior doctor. It should be senior doctor to senior doctor. One final thing that not everybody understands is the consumer view. So what is quality in healthcare? Because often we talk about quality as mortality or morbidity, but there's lots of literature around the world, and there's no doubt if you ask a group of consumers what's their number one quality item, it's always access. They want a service that's accessible. They want it to be appropriate to their needs. They like to see the same person. They want continuity, and they want the service to be responsive to their needs. They rate all of these higher than what we would talk about, which is safety, let alone effectiveness, and let alone dollars. So it's important to understand that people's perspectives, this was studied in Acute by some years ago, and a group of patients said, or potential patients said, they would have the operation even if they knew they were more likely to die, because access was at least as important to them, in fact more important to them. So when you look at different health services and when you're doing a VASM review, just remember you might be comparing apples and oranges. They will be different. And what we need is a system where the apples and the oranges blend together seamlessly and everything works. So look, just in conclusion, occasionally our patients choose to have their health care in less than ideal circumstances, or what you or I might regard as less than ideal settings. Emergencies are an ongoing challenge to us, and even well-planned and well-executed operations can have unexpected complications. When we rescue patients, we may need to transfer them, and good communication is the key. Thank you.